Hi, everybody. Today is our discussion of concepts in program design and development. This is inclusive of the Chapter 7 content in Curly. We started on some of the Chapter 7 content last time, but that was really just to sort of touch on the way that programs are kind of conceived. And the white paper that Robert Wood Johnson Foundation was talking about in terms of innovative care delivery models. So today we're going to get more into how do you actually step-by-step work through development of a program, and provide you with some information about the W.K. Kellogg logic model, because that's also part of your reading for this week. So without further ado, by the end of today, you should be able to determine appropriate sources and levels of data to support programmatic choices, identify steps in the development of a successful program, and describe program models that you could use to guide the process of program development. The text talks about how important it is to have really accurate information as you start to analyze the need for a program and analyze sources of baseline data to develop that program. And so one of the different levels of that, those data are population level data, organizational level data, and consumer trends, attitudes, and beliefs. So when they're talking about population level data, this is again kind of speaking to some of the data sources that we've examined in some of the other chapters. And this is, I think when I was a graduate student, I didn't really perceive how many of my textbooks, they're edited by one person, but each chapter is written by different authors. So those authors don't necessarily know what each other has already submitted in previous chapters specifically. So that's why there may seem to be some redundancy and repetition of information that you may have already learned, and or referencing those pieces of information but in a different context because it's written by a different author. So some of the population level data sources we've actually discussed in previous chapters. So the Department of Health and Human Services, ARC, and CDC are three of the data sources for population level data that have been discussed in the chapter, and then in previous chapters, and then in this chapter they're also referencing those. They also talk about clinical registries, which we touched on a little bit, and databases that we've also talked about. But in the chapter 7, they do have some good links to other parts of those websites. So, for example, the National Quality Registry Network and the ARC Registries for Evaluating Patient Outcomes User's Guide are both, additional components of each of those websites. So we've been referencing the information that you can access at the HRSA website and also at the American Medical Association just in general, but this is specifically the inventory of national clinical registries and then the National Quality Registry Network website. So those are just kind of two pieces that are a little bit more specific. But what I think the point that they're trying to make with referencing these data resources is that what we do when we initiate program development is determine some baseline measures and make sure that those measures correspond with existing measures that are recognized nationally, so that you're not just choosing measures that may not be a valid tool for assessment of the quality of care that's being delivered, or the expected patient outcomes, etc. So that you should always validate the outcomes that you're tracking with a reference point in population level data. In terms of organizational level data, this is probably the kind of data that you're more familiar with utilizing. So if you work for Hartford Healthcare, or you work for Trinity Health System, or you work for Yale, or any of the big health systems, they are going to have organizational level data and standards that you should be able to track your progress against. So you should be able to access certain kind of trends and compare the intervention that you are implementing against the organizational trends. So for example, the chapter's talking about if a hospital's readmission rates for patients with heart failure trend above the national benchmarks, an APRN could look at specific social determinants to determine which patients might benefit most from a transitional care program to minimize readmission rates. So the good thing about utilizing organizational level data is that you can show temporal trends. So you can look at how the work that you're doing compares to how the organization performed in the same area maybe 10 years ago, or 10 months ago, whatever the relevant time period would be. So there's the temporal aspect of comparison, but there's also in terms of performance. And if you're initiating, for example, a new quality improvement bundle, that you should be able to benchmark, before the intervention starts, so that you have, a milestone to compare to once your intervention has started. So there's no sense of, bias, because you've placed your intervention within the context of the current parameters of practice where you are. And then finally, consumer and societal trends and demands. It's always important to take a good look at the desire of a community for a program or for an intervention. And so, people may recognize that something is needed, but they may not be willing to seek it out. So, for example, people recognize that obesity is a problem. However, they're not willing to put in place certain, laws that would restrict the types of foods that are available, as an example. I think it was about 5 years ago that it was probably even longer than that now, but Mayor Bloomberg wanted to outlaw extra large sugary drinks, the kind that you would get at like a 7-Eleven, like an extra large Slurpee. He was like, there's no need for that large of a dose of sugar, and let's just, outlaw them. But it was, it wasn't met with the welcoming attitude by the people of the city, and I don't think it ended up passing. I think people, they're not as willing sometimes to come out for big social changes like that. And so it's important to take those types of attitudes and beliefs and trends into account. It may seem like it's, it would be very effective to send everyone to an 8-week camp to learn how to practice effective weight management, for example. But who has time to be in person at a camp for 8 weeks? while that may be the intervention that's the most effective, it may not be the most feasible. It may not be the most practical, and it may not be where people are. I think if you initiated an 8-week intervention on a cell phone that people could use to track their caloric intake and exercise output, the way that people have started to use their smartwatches, I think that's responding to current consumer trends better than something like a in-person class or a camp. So anyway, the ways that we think about developing programs are very sometimes they can be very linear, and I think the chapter makes a good point of kind of pointing out that thinking in a linear way doesn't always benefit us, because in a lot of times when we think first we have to do this, then we have to do this, then we have to do this, and they all build upon one another, it's harder to anticipate problems when we think in those terms. And so in this chapter, I think they do a really good job of explaining how you have to be kind of thinking on multiple levels when you're working through the development of a program. So first, they talk about the importance of justifying the program. The program should be data-driven. There should be clear expectations for stakeholders, roles for those stakeholders, and a lot of times the most successful interventions are those that are bundled. That those that are singular are it's hard to measure bundled interventions in some ways, because it's hard to tell what was the strongest component or what was the component that caused the behavior change. But by that token, then it's because bundling interventions allows for this more kind of organic complementing of multiple factors that may play a part. So bundling interventions is recommended because it saves time and it saves energy, and it's a better often use of resources, because one resource can be used for multiple components of an intervention. It's important also to make sure that the intervention aligns with your organization's goals, so that you can use existing evaluation strategies, and also be kind of keeping in mind the ways that the work that you're doing can be highlighted by other elements, other programs that your organization is already supporting. It's a good way to get buy-in from leadership also, is to make sure that it aligns with those existing goals. Trying to strike off in your own direction, oftentimes you won't get buy-in from administration and leadership, and it can be more burdensome on you as an individual team member, rather than kind of developing a program that's a complement or an extension of an existing organizational intervention. And then it's also important to think about how whatever you're proposing is cost effective and potentially could save money for the organization, because that's another way to kind of get the buy-in of the leadership for longer term support and sustainability of the program. The next component of program development is assembling a team, and this is often, when I was talking about getting buy-in from administration, an executive sponsor is so critical to the success of a program. If you don't have the buy-in, but also kind of the credibility that an executive sponsor, so somebody in a leadership role, or somebody who's a trusted messenger already, or someone who's at an executive level in your organization, then you're swimming upstream, because unless that person or those people have given their blessing to your intervention, you're not really going to get anywhere with it. Or you may get somewhere and then they may be frustrated that they weren't given notice of that intervention so that they could be talking it up, and then they're kind of blindsided by the progress that you've made. So it's critical that you think about politics. We always have to think about how something is perceived, and not just how it actually takes place, but also perception. Public perception is important, particularly if you're working in an organization that's a large organization. And many of the healthcare organizations now in our current healthcare climate are kind of ginormous organizations. There should be a process owner, and I think if we're talking about you as a designer of an intervention or a program, this would probably be you. So whoever is designing the program, but also making sure that all of the steps are being taken to implement it effectively. That somebody has to be responsible, the key person for following everything all the way through. And then you have your team players. Those are the folks who you can count on for implementation. They're also the early adopters, the folks who are like, oh, that's a good idea. It makes sense. We think it's a good idea. We're going to try it, and we're going to follow, the prescribed program to a T so that we can demonstrate success. And so it's really critical that those people be chosen carefully, because if you get somebody on the team who is critical, they could kind of take the program off course pretty easily. And I'm sure that some of you guys have seen that in practice. You have your naysayer or your detractor or your person who's jealous that you came up with an idea that they didn't come up with, or they've been saying this and you organized it, and they're like, but I've been saying this forever and nobody ever paid attention to me, so I'm going to try and tank this program. Like, I've been in several of those situations. So I think it's just important that you keep those team players involved, keep them invested, keep communication lines open, welcome their feedback and their input, and show them that they're valued. And then finally, stakeholders. And stakeholders isn't just the people who are already involved with the program, but also the people who will benefit from that program. And then what was the other point I wanted to make about this? They talk about the Together Everyone Achieves More acronym. That's, I don't even know where that came from, but it's kind of typical acronym. But I think commitment, I think in the chapter, in this section, they say commitment, communication, and collaboration are some of the most important characteristics of a team for a program's success. And I think that's absolutely true. I think probably communication is highest among those. And then finally, giving the program structure, the goals, objectives. It's important that everybody understand where we're going with this, where, who's involved, what the plan is, what the program is, when we'll be taking stock of progress, why we're doing it, and the actual implementation plan. So it's critical that you think through these elements before you get started, because if everybody on the team is not involved in understanding the mechanism for success, then there's no way that you can actually be successful. So the text kind of jumps right into discussion of outcomes, but I think if you don't have a background in quality assurance and you haven't ever taken a course on program development or evaluation or anything, it can be confusing. The terminology can be a little bit confusing. So I just want to kind of step back for a beat and say that goals, objectives, and outcomes are how you kind of work through strategy for implementation. That the idea of strategic planning, it always starts with, what is your goal? What is your mission? What is your vision? So what is the what that you're going to do? And the vision is what you expect to see when the mission is realized. So those parts aside, when you get down to kind of the nuts and bolts, the goals, objectives, and outcomes are sort of the next level of realization of the program, realization of the mission, and how you're going to actually achieve the vision. So a goal is a statement of a long-term future situation, condition, or status. In our case, it's a health status. Goals are stated in terms that are not measurable. They're usually aspirational, but they're attainable. So we'll give an example on the next slide, but goals are sort of like a goal could be world peace could be your goal, and then it's big, it's aspirational. You're trying to achieve something big, but it's attainable. Maybe world peace is not a realistic example, but it's something that is usually attainable, but it's that big effort. Like, what are you moving toward? Objectives are statements of expected activities that are SMART. So they're specific, they're measurable, they're attainable, they're relevant, and they're time-bound. In the text, they talk about outcome objectives, and so you can use that terminology, but I find it easier to think about these in terms of a tier. You have your goals, you have your, probably your overall program goal, and then you have several objectives that you intend to accomplish as a way to realize that goal. And then the outcomes are the changes that should result from the intervention or the program. So those are the measures that you are going to see change in, or the indicators of change that you're going to be tracking over time. So in that way, I think about these as tiers. So you have a goal, several objectives. With each objective, you have specific outcomes that you would be tracking. And within those outcomes, then even you could have specific indicators or measures that you're more specifically tracking that, if realized, would mean that the outcome has been accomplished and that you're that much closer to realizing that objective toward that goal. If that makes sense. So we'll give an example. A goal would be to decrease violence in middle schools in Waterbury. Over the past 2 years, we've seen an increase in the amount of interpersonal violence in schools in general across the country. I think as a result of the pandemic and as a result of multiple factors, but the pandemic has worsened. An objective would be by 6/2023, we want to decrease by 50% from 6/2022 the number of fights in school through peer-led conflict resolution programming. So this is a SMART objective in that it's specific. So you're talking about you're decreasing the number of fights. If you decrease the number of fights, that's going to move you towards your goal of decreasing violence. It's measurable. So you're talking about decreasing by 50% in 1 year's time from 2022 to 2023. It's attainable. You have a specific program that you've studied and you've determined, is it a program that would make sense to implement in this context? Is it relevant? Is it relevant to the mission? Is it relevant to what we're trying to achieve? Yes. Peer-led conflict resolution programming is relevant to decreasing number of fights and thereby decreasing the violence. And then, is it time specific or time sensitive or time bound? And here it is. We're saying that in 1 year's time, we want to see a decrease by 50%. So this objective is SMART because it checks all of those boxes. You want your outcomes to be similarly SMART, but I feel like the objective is if you're smart with your objective, then you can be a little bit less uh, smart with your outcome, because your outcome is a measure. So the measure that you are going to use to track the success of this objective is by 6/2023, so by the end of this time period, principals will report 50% fewer school fights as evidenced by, that's what AEB, as evidenced by data management system audit. So there's a data management system that's used by the principals in the school to track the number of incidents where the school resource officer is called, or the principal is called, or it's observed on a camera in the school, and those are tracked through this data management system. So the outcome is that piece of data. What's that number at the end of 6/2023? So this is an example of how you could set up your goal, your objective, and your outcome. Now here I just also want to take a step back and acknowledge that the quality improvement process, the PDSA that they reference in the chapter, it's nothing new to nursing, and I'm surprised that they don't really reference the nursing process. That, you know, from the time of Nightingale, we've been assessing, planning, implementing, evaluating, and reassessing, right? That's the API kind of process that's what we do in nursing. We assess patients. We, assess their vitals. We assess both subjective and objective, signs and symptoms. We develop a SOAP note. We do a subjective, objective assessment and a plan, right? So it's the same thing when we're talking about looking at populations. We assess a population, we look at relevant data, we look at comparative data so that we have something as a baseline, we look at their baseline. We develop a plan, we determine who do we need to involve, what are the resources that we need, what's a realistic timeline. We implement the intervention, we start a program, we put in place evaluation measures at the time that we are implementing the program so that we have something to compare as a baseline, but we also have points of data on regular intervals that are relevant to the intervention. And then we look at those data, and then we reassess, has there been any change in the health of the population as a result of the intervention that we implemented. So this is the nursing process. The same thing can be said for Deming's model for quality improvement. Plan, do, check, act is not that different from assess, plan, implement, evaluate, reassess. So I just want to say that because I think a lot of times quality improvement folks or quality assurance folks think that they invented this stuff when Florence Nightingale was talking about it in 1855. So just want to put that out there. And Deming didn't, excuse me. Deming didn't start talking about it until the late 70s, early 80s. Okay, so how do we work through implementation? There are several components that it's important to think about. So we already talked about building your team. We already talked about looking for relevant data for comparison. Now, if you're actually getting into the implementation of a program, it's important that you have some policies and procedures for operation, because you want all the members of the team to be implementing it the same way every time so that you have good data that's generated as a result. So when you're developing your policies and procedures, you should be thinking about how they align with existing policies and procedures, making sure that there's nothing that's going to deviate from an existing policy of, your workplace, for example, that would interrupt the ability of the people on your team to carry it out as planned or designed. It's also important that you be thinking about what kind of support you need. Like, do you have the people to be able to carry this out? Do you have administrative support? Do you have not just clinicians and clinical support, but do you have, folks who can do data entry or data analysis? Making sure that you are kind of following up and doing the evaluation in real time so that there's no delay in collection of data. And then communications is really critical, especially now. I think we're in a digital age and we can't be developing flyers and booklets and handouts anymore. Like, it's critical that everything be accessible electronically, that we be thinking about accessibility in terms of communications, and that we be using the most current technology so that we are inclusive, because folks with hearing or visual or learning disabilities or different levels of English reading ability, they still need to benefit from your program. So it's a lot of times the technology that is further ahead than our more kind of traditional ways of thinking about communications. And so looking to those adaptive technologies is critical when you're thinking about how you're going to roll out your intervention. You can't just leave out a group of people because they take the world in a different way. Another important component is, social media. How are you going to convey the information on a broad scale, and how well can you control who receives that information and how it's perceived? Are there, communications experts that you should bring in to analyze the proposed intervention, and what would be the best way to involve them? And, do you need to do some focus groups? For example, when we did our Healthy Texas Babies initiative, we knew that, we wanted to reach women of color, particularly African American women, with messaging about preconception, wellness, and health. And we did focus groups. We did a whole series of key informant interviews. We did surveys, state level surveys, both telephone surveys and opt-in electronic surveys, to get feedback about how people preferred to get that kind of information, and where would be an appropriate setting, and what would be the appropriate medium through which to convey those kinds of messages. And that kind of pushed us towards doing a beauty and barbershop outreach campaign about preconception and about the importance of having a trusted healthcare provider so that you could have an honest conversation about planning your pregnancies, or if you don't intend to be pregnant, getting on a kind of birth control that is going to work for you. So it's really important that you engage those people so that they can kind of provide some of that analysis of the priority populations from a meta level, from the 30,000 foot view, because the way that we interact with the world is face to face. We don't often have access to those types of user profile data from Facebook or market data to determine where our message would be the most welcome. So it's important to consider those components. And then marketing and market analysis. Market research helps you to understand how interested your consumers may be, how interested providers may be to adopting this new change, and whether there's, there may be a need. I'll give you an example. I used to have a nonprofit that where I trained members of the refugee and asylee community in Baltimore to be community health workers. And everybody that we worked with was like, oh, this is such a great program. These folks, they know their stuff. They are able to help new arrivals with the kind of issues that are relevant to them, like how to go to the grocery store and not get overwhelmed, and how to deal with PTSD, and where to get resources, and how to enroll your kids in school. Very, very necessary programming. But when we did a market analysis to see, okay, where could we employ these people? And granted, this is back in 2007, so it's before the ACA. There were no employers. There were no health centers, clinics, nonprofits that had the funds to be able to hire these people, because at that point they couldn't be reimbursed with Medicaid or any insurance company. Nobody was talking about reimbursing community health workers at that point in time. So this program, which everybody, universally acknowledged that it was valuable, it wasn't marketable, because the market analysis found that while there was a need for it, there wasn't a mechanism, there wasn't a means to pay these people. And so for the people getting trained, they were just getting trained in something that they would just have to be a volunteer at. And that's also not sustainable. So it's really critical that you think kind of 2 steps ahead, think about the future of this program, and are you just doing it as a demonstration? Is it just a pilot? Or are you planning to make it sustainable? And if you're planning to make it sustainable, you should be thinking early on about how to make it sustainable. You're not going to start pushing an experimental drug that's really successful, but that costs $2 million per dose, unless there's a way to pay for it. So always be thinking about how you're going to convey the importance of the program to the consumers and other stakeholders for sustainability, but also analyzing the market and whether there's a need and a desire for it. Okay, so next we're going to go into a few of the models that were discussed in the chapter. The great thing about using a model is that it asks you these questions in a sequential order. All of the kind of components that we've been saying that you need to be thinking about, the costs and the cost benefit analysis, and the population that's going to be served, and what are the data that you have to justify your intervention, and what's the structure of your team, and how are you going to do evaluation. All of those things. I've been just talking for 20 minutes, 25 minutes, 38 minutes now about these. But the value of using an organizing framework like one of these models is that it walks you through, so you don't forget any of these components. They don't kind of fall off your radar. So the one that I am proposing that you use, and that I'm putting here first, and I've asked you to read about, is the W.K. Kellogg logic model. There's several different varieties of logic models out there. I think I have found over my career that the logic model developed by the Kellogg Foundation is the one that I go back to again and again, because it's simple, it's straightforward, and I think that the implementation guide that accompanies it explains it very clearly, and it doesn't get overly complicated. But the intent of a logic model, just like with any of these frameworks, is to map relationships among resources, activities, and intended results. So we're going to keep talking about the Kellogg logic model in the next couple of weeks, just so that you can feel like you're comfortable using it and prepared to use it. as you do your logic model assignment. But I want to touch on some of the others that they mentioned because they're also relevant and they may be easier for you to use. It depends on your specific intervention. The framework or model of change is a 12-step process to organize thoughts and orient program development through intended program outcomes. It's part of the community toolbox, which is just a great resource. I think I've mentioned it on one of the previous lectures, but this is just a great resource to always keep on your bookmarks because pretty much anything having to do with development, assessment, development of a program, fundraising, program evaluation, integrating racial equity into your programming. It seems like they have everything in there. It's essentially a community organizer's toolbox, but it is relevant for the work that we do as health professionals too. So their model of change that is kind of outlined is a 12-step process to organize your thoughts by looking at what the outcomes. So it's kind of looking at the outcome and working backwards, similar to the way that the logic model. So I would encourage you to check out this link, and I'll put the slides up so that you can navigate to that link. But check out the community toolbox. It's part of the Kansas University community toolbox, and it's very valuable. And then the evaluation framework for community health and the precede proceed are both models that I put them together because they're really intended, I'm sorry, and I can't go back, because they're both stakeholder driven a lot. They're both participatory evaluation models, program development models, which means that they involve stakeholders. So the stakeholders are not just the recipients of the information or recipients of the services. They are helping to guide the development of the service or the intervention. So it's a different way of thinking about it than the way that we've, in public health typically done, and even in nursing, it's kind of always a top-down assessment of a community, and then we decide what's best for the community. Both of those models, the precede, proceed, and the evaluation framework for community health, are involving participants in very real ways in the work. So I put those kind of together because of that commonality. Okay, so I'm going to skim through, not going to skim through, but I don't want to belabor this because you're going to be reading this, and I'll talk about it a little bit more next week as well. But the Kellogg logic model is a logic model that once it's created, you can read it from left to right. And this is sort of the way our brains think about programming. And this is the way that we tend to think about building programs the way we think about building a house. So do we have the resources that we need to build the house? So do we have the bricks? Do we have the concrete? Do we have the wood? Do we have the nails? Do we have the resources? And then what are we going to do to build the house? We're going to, bang away at those resources and put them up. And that's going to create the shape of a house. And then, the outcome is that we'll have a shelter. The impact is that then we have a place to live, right? So it's sort of like stepwise the way we think about it. Like if we think about a program, certain resources are needed to operate your program. Those are the resources. Those are the things that we're putting in. Those are the money and the technical expertise and the space and the medical equipment. And then if you have access to them, the resources and the inputs, then you can use them to accomplish your planned activities. So if you have those resources, then you can create activities. If you accomplish your planned activities, then you will hopefully deliver the amount of product and or service that you intended. So if you do your activities successfully, you should show evidence of those activities, right? Those are the outputs of the program. So your activities are training community health workers. The outputs would be community health workers. If you accomplish your planned activities to the extent that you intend, then your participants will benefit in certain ways. So the outcome of training community health workers is that people in the community will have better ability to navigate to health appointments, for example. So your resource is you need community health workers, you need a training program. The activities, training them. The outputs, trained community health workers. The outcomes, those changes in the community's ability to navigate because of the assistance that they've gotten from the community health workers. The impact is if these benefits to participants are achieved, then certain changes in the organizations, communities, or systems might be expected to occur. So overall, the impact would be the community health workers helping people navigate to their appointments results in short-term outcomes. People don't miss as many appointments. Long-term outcomes, people have better control of their health care and their health. And then impact, more refugees are meeting benchmarks for quality health maintenance over time. So that's your impact. That's what you're trying to get to. That's the societal change or community level change that the outcomes being realized and the activities taking place will accomplish. Okay, the challenge is, while this is the way that we think, this is not a practical way to build a program, to work through a program. So the Kellogg model actually starts with the outputs. If you accomplish your planned activities, then hopefully you will deliver the amount of product or service that you intended. So thinking about what are the outputs, what are the services that you want to demonstrate have been delivered. So what are the things that your program is going to produce? If you think about that first, you're thinking in very tangible terms about what the demonstrative, tangible, able to hold in your hand kind of change, or even profit. It could be an output. The things that you can count, those are your outputs. So those are your indicators, the things that you can actually say changed. Next, you're going to look at your outcomes. So if you accomplish the activities that you're planning to do, then your participants will benefit in certain ways. These are the things that you can track. These are the things that you are able to quantify. These are the measures that you're going to use to describe progress towards your ultimate goal. Then you're going to look at impact. What is the ultimate impact that this intervention should result in? Then you go back to the activities and build the activities out from there. So in order to see this impact and deliver these outputs and be able to measure the outcomes, what are the specific activities? So if you work kind of backwards like this, excuse me, it helps you avoid wasting resources. It helps you think through what are some of the possible unintended consequences. And it also helps you kind of think through each component of your program completely without missing something and having to think or having to start over, or realizing that you didn't collect the data that you wanted to collect in order to show that change was taking place that you were intending to change. And then finally, what is the resources or inputs that you need? So after you've developed all of that, like what is the vision for the program and what are the activities that are going to take place to support the larger impact and the accomplishment of outcomes, then you can really say specifically, what do I need? So it's almost like, instead of thinking about it as building a house, it's sort of building a house backwards a little bit. Okay, so the evaluation framework for community health, this is the one that I said was more participatory, and I'm not going to dwell on this too long, but first step is to engage stakeholders and then describe the program, make sure that you get buy-in, focus the evaluation design, gather evidence, justify your conclusions, and then ensure the use and ensure that the intervention is used, share lessons learned, and make sure that you're keeping your stakeholders engaged by sharing what was learned by the intervention. So the precede proceed, these are the steps in the precede proceed model. Precede standing for predisposing, reinforcing, and enabling constructs in educational diagnosis and evaluation. So first you're doing a kind of an assessment of the community, then you're doing an assessment of the data, then you're looking at what are behavioral and environmental factors that may impact the intervention, and what might be needed, and looking at educational and organizational needs, and determining how you're going to build those into your program. Administrative and policy needs, and building those into your program before you get to the point of actually designing the intervention. So then your second half of it, the proceed part of the model, is policy, regulatory, and organizational constructs in educational and environmental design. Implementing, doing a process evaluation, which is looking at how did you do the intervention the way you intended to do the intervention, and then doing your impact evaluation. Did you change the thing that you were trying to change? And then your outcome evaluation. Did you achieve the goal that you intended to achieve with this intervention?